Hi, good morning and good afternoon, everyone. This is Beth Galella. I am an analytical scientist from Bristol Myers Squibb, and I was previously co-chair of the IQ Pediatric Working Group. On behalf of the working group, I have the pleasure of introducing our speaker today, Dr. Rachel Myers. Dr. Rachel Myers was invited to our pediatric workshop last year, and with her experience as a pediatric clinical pharmacist, we were thrilled that she was willing to present at our webinar. Rachel Myers, Associate Professor at the Ernest Mario School of Pharmacy at Rutgers University, and the Pediatric Clinical Pharmacist at St. Barnabas Medical Center in Livingston, New Jersey. In her current position, Dr. Myers provides both didactic and experiential education in pediatric pharmacotherapy for pharmacy students and residents. She practices in both the Pediatric Intensive Care Unit and General Pediatric Unit at St. Barnabas Medical Center. I would also like to mention at the conclusion of this webinar that you will receive an email from Mahalea with a feedback survey. It is very important to the speakers as well as to us as moderators to ensure the quality and value of our webinar series. So we really appreciate your feedback. And without further ado, I would like to turn it over to Dr. Rachel Myers.
Thank you, Beth, for that introduction. Again, I'm Rachel Myers. So my role is that I'm faculty at Rutgers, but I also practice clinically, and most of my time is spent taking care of children at St. Barnabas Medical Center here in New Jersey. I'm just going to advance. There we go. Okay, so a couple of disclosures. I have received grant and research support from Catalent, and I have done consulting for Bristol Myers Squibb. I will be discussing some off-label use of medications, including dexamethasone, nifedipine, and albuterol, and we'll be discussing several brand name medications. This is not meant to be an endorsement of any particular product, and on the reverse, this is also not meant to condone any other products or say anything negative about products. I'm just going to be sharing with you what we do clinically and some of the issues that we have. So we're going to be talking about a lot of different dosage forms for children. Most of what I'm going to be doing is sharing my experience in the hospital and our experiences in the hospital, but we'll be talking about some over-the-counter issues and issues that our parents have in the home as well. So we'll talk about some dosage forms. We're going to go everything from parenteral to oral. We're going to talk about tubes, all different things. And we're going to talk about some ideal qualities for pediatric medications. So I think everybody in the audience is familiar with the Best Pharmaceuticals for Children Act and the Pediatric Research Equity Act. As of the end of 2019, this has resulted in 781 medications with new pediatric studies, which is great. But of course, we know, as C. Everett Koop said many years ago, drugs don't work in patients who don't take them. I often joke with my students that I'm the daughter of a veterinarian, and a lot of the skills that I learned from him and how to get dogs and cats to take medications is something that I have unfortunately needed to use in my own children to get them to take medications. So there's a lot of overlap to me between veterinary medicine and pediatrics. So we're going to start with a quick case example. And this is a 5-year-old, 16-kilo patient with strep throat. This is something that I've experienced, unfortunately, a couple of times. I have 2 children, and there was about a 2-year period a couple of years ago where we seemed to be getting strep throat a lot, and I gave a lot of amoxicillin during that time. And so a standard prescription for a patient of this size would be amoxicillin 400 milligrams twice daily for 10 days. It's fortunately available as a 400 milligram per 5 ml concentration and a 100 ml bottle. So in the pediatrician's mind, they're thinking 5 mLs twice a day for 10 days. That's 100 mils. It comes as a 100 ml bottle. Perfect. And that's what I have always been prescribed for the 2 or 3 times that I've done this just at home. But as I'll share with you, it doesn't quite work out that way. So in these pictures here, and this is from a study that we did, which I'll expand upon, you can see the problem that parents are going to have at home. So a few years ago, the American Academy of Pediatrics actually came out with a statement that said that the preferred dosing instrument for children for liquids is an oral syringe. I know when I was growing up, my parents always used a teaspoon to give me medications. That was kind of the standard thing. There's all kinds of other dosing instruments out there. There's those measured spoons, et cetera. But we know now that really the preferred agent, because it's the most accurate, is these oral syringes. Here's the problem that it poses, and again, this is the image on the left here, is that when you get about a little over halfway through the bottle, the syringe doesn't reach the bottom anymore. And so what you end up having to do is pour some out or tip the bottle in order to get the syringe tip into the liquid. And so it becomes a very messy ordeal, and you end up losing a lot just in terms of if you're transferring it to a small bowl to draw out of, or you spill some while you're trying to draw it out, it becomes quite difficult. The image on the right shows what we use in the hospital, which is a bottle adapter that the oral syringe can fit into and draw up out of quite easily. And so that's ideal. But unfortunately, at least in the United States, these bottle adapters are not commonly used. I have never personally received one from a pharmacy, except actually, I take that back, one pharmacy, but that pharmacy is now out of business. So this is just not something that's done in the United States. And so I have never been able to finish a course of amoxicillin for the full 10 days. So what we did is we actually decided to study this. This is a poster that we presented at a meeting last year where we actually took 6 commonly used medications. I bought 5 bottles of each. And we measured, there were 3 pharmacists. I had 2 pharmacy residents with me, and we just spent a day in a conference room. It was a very sticky, messy day. But we drew up all the doses, and we wanted to see how much could we get out of each bottle, and were we actually able to draw up enough doses to complete a typical course for that antibiotic. So I will say that for the amoxicillin example, which is on the left of that top graph, we were able to get more than 100 mLs out, which is good, probably because it was done by 3 pharmacists in a setting where we were doing it all at once. But at the same time, you'll see some drugs like azithromycin, we were not able to get the full 30 mLs out of, and same with ceftonir, the 60 ml bottle, we were not able to draw out the full amount. And so again, we tested these with and without adapters. And our secondary outcome was looking at the courses of antibiotics that we were able to complete. So you can see that without an adapter, 25% were not able to be given as complete courses. So that means that parents at home would not be able to finish the course of therapy with the amount that's in the bottle. The other piece you always have to remember with when you're dealing with children is the possibility of them, spitting some out. Or, I have a friend who said that her daughter took the syringe and squirted it into her milk and claimed that she was done. And so we lose some medications, unfortunately, too. And there's just no way sometimes of predicting those. But sometimes a little extra in the bottle really can help. So we're going to bounce around here and talk about a lot of different topics. So we're going to transition now to NIOSH. This is the National Institute for Occupational Safety and Health. And their main objective is protecting people on the job. And in 2016, they came out with a list of drugs that were considered hazardous. And this list is quite lengthy. And it included a lot of drugs that we had not considered as hazardous in the past, including a lot of anti-epileptics and drugs such as tacrolimus, which at least at my hospital, we're a major kidney transplant center. We use a lot of tacrolimus. And so now the way we handle it in a hospital is quite different than how we used to have to. Now, remember again, NIOSH is interested in protecting nurses, pharmacists, technicians who are handling these drugs. Unfortunately, what it does not address is caregivers. And so parents that are handling these medications in the outpatient setting, unfortunately, are being exposed. And so that's something that we're trying to transition and do more counseling for parents that are handling these medications to make sure they're wearing gloves and using appropriate precautions. There's really generally, from what I've seen, no information, instructions for use in these medications for parents on protecting themselves, because again, the idea of these NIOSH guidelines is to protect healthcare workers and not really caregivers. It's a very difficult conversation to have, by the way, with a parent to tell them they need to wear gloves when handling this medication, but of course their child is going to swallow the medication. So it's always a difficult and delicate conversation that we have to have with them, but it's necessary in order to protect them from the medication. They don't need the risk when they're not on the medication themselves. And so also we have to think about crushing of medications. So sometimes I've had patients who are on, say, topiramate, and a lot of times I'll try to make their dose a tablet size because it's easier for parents to pick up even if their patient or their child has a tube, like a G tube, they can crush it sometimes and put it down the tube. But when NIOSH came out, I stopped recommending that because I don't want a parent having to crush the tablet at home every day and expose themselves. So now I recommend that they actually compound it and get a compounding pharmacy to compound the suspension, so that the risk and the exposure to the parent is less. So we have to think about all of those things, even things like diapers. What if there's drugs still in the diaper? How is that handled differently? And that really hasn't been addressed. Tacrolimus, again, is a medication that's on this list, and we use it a lot at our hospital. They came out with an oral suspension a couple of years ago, and basically they're packets of powder that are mixed, which is great, and we always appreciate these commercially available products, because generally the way we give it in the hospital is it comes IV, but it also comes as capsules, and we sometimes need to compound a suspension. The capsules also are often opened, and we can sprinkle them in food and administer them that way. When this came out, however, it really became quickly clear that it was not something we could use in the hospital, because when we're preparing these doses, this is not something that we can let our nurses handle according to the NIOSH guidelines on the floor. And we can't prepare it in the pharmacy and send up because it's really meant for immediate use. In other words, you take the packet, you mix it in the water, and then you administer it to the patient right away. And again, this is way too much exposure for our nurses. So it may be acceptable at home, but not in a hospital situation. And again, the other thing to think about at home is there's no recommendations here for parents to wear gloves or protect themselves in any way. So there's really just such a difference between how we handle these medications in the hospital and how we handle them in the outpatient setting. So we're going to talk some more about things we do in the hospital. I always say we're making it up as we go along. I found that when I was training to be a pediatric pharmacist, a lot of what I was taught and the way we go about our work is taking dosage forms that we're given and manipulating them to make them do the things that we need them to do, because they're not ideally suited for our patient population. And I guess what started to strike me, especially when I had my own children, was, is anybody telling the industry about this? Are we talking to them about these needs that we have and all the, the tubes that we use and all the diets that we have our patients on, and we need to know about carbohydrate content and all of that. And that didn't seem to be the attitude. In general, the attitude is, here's how you manipulate. Make sure you teach everybody that this is the way you manipulate this new dosage form. And so I'm trying to help bridge that gap and talk with industry folks about these issues, but also trying to raise awareness of my pharmacy colleagues that we need to start letting industry know and having these conversations with them when we come up with these issues. So when we dispense medications in the hospital, most of them will go to what we call our automated dispensing cabinets, or ADC. And there's a picture. This is a common one that's out there. This is an Omnicell machine. And it's basically loaded with as many medications that are going to be used commonly in there. For example, acetaminophen, or say an amoxicillin tablet, azithromycin tablet. And the process is generally the physician will write the order, the pharmacist verifies the order, and upon verification, that basically unlocks that little cube or that pocket in that automated dispensing cabinet, and then the nurse can take the medication out and give it to the patient. And so again, we put a lot of medications in there because the advantage is these machines are on the nursing units, and so they don't have to wait for the medication to arrive from the pharmacy. Anything that's not in the bins or in the machine that the patient is on is going to be sent up into what we call our patient-specific bin. So each patient has their own bin, and anything they're on that is, again, not in the general stock of the machine will be sent up by the pharmacy. The issue that we have in pediatrics, again, is we have so many liquids. So we have a lot of patients that have to have liquids that are sent up. And a lot of times they're in dosage cups, but mainly in oral syringes. And the goal, again, is for the nurse to manipulate as little as possible. So just to give you an example of some errors that we've encountered along the way because of some of these dosage form problems, this happened a few years ago. We had our levetiracetam, which is an anti-epileptic, dosage cups, and they were 500 milligram per 5 ml. They were stocked in our cabinet. They had been labeled as 100 milligram per ml, and then in parentheses it said 5 ml. So we had a nurse who received an order for 500 milligrams, and so what she did was she looked at the oral dosage cup really quickly, and she thought, oh, there's 100 milligrams in here, because she just saw that 100, and so she gave 5 cups. Now, fortunately for this patient, if we were to choose any medication for the patient to get an overdose of, levetiracetam is probably the safest that we could pick. So the patient was fortunately fine, but the nurse was quite traumatized and very, very upset. It was a fairly new nurse too, so her confidence was kind of shattered. But there's some things that we do in patient safety to help prevent these kind of errors. So now we label our cups as 500 milligrams / 5 mLs, and we also took those out of the automated dispensing cabinet. So we draw these doses up now in the pharmacy. So the technician draws it up, the pharmacist checks it, and then the nurse can give it. So we have 3 people involved rather than just the nurse on the unit. We also do a lot of barcode scanning in the hospital now, and that's considered a standard of care in terms of patient safety. And so the nurse will scan the patient. The patient will wear a wristband with a barcode on it and then scan the medication. The issue is when we scan, say, a tablet, say an acetaminophen tablet that's in a unit dose pack, you know that's correct because it came from the manufacturer that way. For liquids, if we're drawing them up in syringes, let's say the technician drawing it up picks the wrong antibiotic. Instead of amoxicillin, they pulled azithromycin and they pulled it into the oral syringe. The barcode is going to be on the label that we print, and so the barcode is not going to be able to tell if that's actually the correct medication. It's only going to be the one that we printed and we put on that syringe. And so it doesn't check everything, unfortunately. So it's a great advance in patient safety. But again, in pediatrics, we don't benefit from it as much as they do in the adult world. We do require double checks for some of our more high-risk medications, such as insulin, to avoid errors with them. Syringes pose other problems. Oral and parenteral doses are drawn up in these syringes. We draw them up in the pharmacy, and then we dispense them to the floor. Ideally, they're going to be used that day. So for our oral medications, we generally send up a 24-hour supply. And in our IV syringes, we have a couple different batches that we make during the day, and they're delivered, I think, 2 or 3 times a day. We deliver IVs. So again, it's meant to be that we're making them pretty much just in time, and they're going to be used. But again, we still have some that are not used, and if we don't use it, then we'll generally try to save it until that beyond use date. And the drugs beyond use date is generally just from the manufacturer data or from other references or from the USP 797 guidelines. A few years ago, the FDA came out with a warning specifically on Becton Dickinson syringes, or BD. And they basically said that the rubber stopper in these syringes had been shown to have potentially drug loss if drugs were stored in these syringes because of the rubber in that stopper. And so they said they are not meant to be storing drugs, and we needed to not do that. Unfortunately, BD is one of the major suppliers of syringes in the country, and so we really had limited options. And so we didn't really know what to do with this information because we had nowhere else really to turn. In 2018, they came up with an update saying that BD had fixed this problem with the rubber stoppers. However, the FDA went on to say at the end of this blurb here that I have on my slide, as we stated previously, the general use BD syringes are cleared for immediate use in fluid aspiration and injection, but not for use as a closed container storage system for drug products. And we have not established the suitability of these syringes with either rubber stopper for that purpose. Now, again, this is something we had to read and say, okay, but what else are we going to do? The syringes that we use, both oral and parenteral, are really not studied for the use that we were using them for in the hospital pharmacy setting. Another example of this is our oral antibiotics that we use in the emergency department. So this is a study that came out a few years ago from the University of Kentucky, but this is actually what we do at my hospital, and most hospitals that I'm aware of do this practice as well. And what we do is we have standard doses of some of the more common antibiotics that are drawn up into syringes and just stocked in the emergency department. And the idea is that this way the nurse can get the medication that she needs and not have to wait for it to be delivered from the pharmacy. And also remember, a lot of these patients that are in the emergency department, especially if they're getting an oral antibiotic, they're getting a dose and then getting a prescription and being sent home. And so the faster we can get that dose into them, the faster we can send them home. Increase or decrease our time for patient stays in the emergency department. And we call it our throughput numbers. So we want patients to come in, get treated, and go home so that they can make room for the next patient. And so what the nurse does is, if it's a standard dose, she'll administer it. But if it's, say, a smaller dose, say she had to give amoxicillin 125 milligrams, she would give half of that. So instead of the 250 per 5, she would give 125. So she would shoot down to 2.5 mLs and give that dose. And what we usually use is just the beyond use date of that drug. So amoxicillin's beyond use date when you reconstitute it is 14 days. So we are potentially storing these medications, if they're not used, for 14 days in these syringes. And again, we have no data about the stability of them, but that's just how practice is today. And as you can see from their results here, their time to antibiotic administration improved in a statistically significant way. So from 57 minutes pre to 17.5 minutes post the intervention. And their emergency department length of stay decreased as well by 40 minutes, which is really fantastic. And any emergency department would be very happy with that. Another example of this is with actually Tamiflu, or oseltamivir, which is obviously for the influenza. We didn't necessarily want to stock the oral syringes of oral Tamiflu suspension. So what we've actually done in our emergency department is we've stocked all the capsule sizes so that patients can quickly get a capsule size, even if they can't swallow a tablet or a capsule. We can open the capsule and give them the contents of that, and they can go home, so they don't have to sit and wait for their oseltamivir suspension. So just for that first dose before they get home, in order to send them on their way quickly, that's what we do. And again, the advantage here is that we don't have to worry about the out date of the solution because the stability of those capsules is obviously much longer, and it can be kept in the automated dispensing cabinet in the emergency department. So that works out really nicely for us. So a couple of years ago, my group here at Rutgers and our resident that year, Samantha Spischak, she did this study looking at how often we manipulate drugs in the hospital between pediatrics and adults. So she's a champion, and she pulled out over 7,000 pediatric medication orders, and then we matched them to comparable adult orders. So that means she looked at over 15,000 total orders from 4 different hospitals here in New Jersey. And what we found was just about 50% of the orders in pediatrics need to be manipulated before they're administered, compared to 16.6% in adults. So there's about 3 times greater amount that we have to manipulate drugs in kids compared to adults. So an example of manipulation, for example, that we counted, and we had all different kinds of manipulations that we included in this study. But an example would be acetaminophen. So an adult, we get an acetaminophen order, they take a capsule, everything's good and done. In a child, we have to measure out the liquid, right? We have to calculate the dose, measure out the liquid. And so there's just, every time we do a manipulation, there's going to be a chance for error. And so we tried to record all those. And again, if you look, the article was just published this spring. And so we go into all the details about the different manipulations that we counted in that article. Nifedipine is an example I always like to give as a medication that was really developed for one thing, and now we use it in quite a different way. So we used to give it for adults for urgent and emergent hypertension, but then it was found, I want to say maybe 20 years ago, it was linked to a high rate of stroke and myocardial infarction in adults, with the thought being that it drops their blood pressure so quickly that they have a stroke. So it's really not used in adults anymore, with the exception, one exception of the adult population is in preeclamptic women. So we do use it for them. But we do use it also in pediatrics. Because generally in pediatrics, we find that they don't have the cardiac history usually that adults do. And so we just have not seen this chance of stroke and MI in the pediatric population. So we still use it for this urgent and emergent hypertension. And the huge advantage is that it's oral. All of our other options are IV. And so, for example, in our clinic offices, if they check a patient's blood pressure and it's really high, a lot of times our physicians will give them a dose of nifedipine right before they head over to the emergency department in case they aren't able to get an IV. And it's just a nice, easy way to give something quickly. The problem is it comes in these 10 milligram capsules. And sometimes, excuse me, I've had my nephrologist order 1 milligram. And so the way we accomplish the 1 milligram is inside that capsule is an orange liquid, and it is 0.34 mLs. So what the nurses will do is they'll take a tuberculin syringe and poke the needle into that capsule. And to get a 1 milligram dose, they will therefore draw 0.03 mLs to administer to the patient. So you can imagine how inexact that is. It is not an easy procedure sticking a needle in there, and I always worry about them getting sharps injuries. So there is a compounded suspension that we can make. My hospital has not transitioned to this because it may delay the therapy, and also just what dose would we make and send up to the automated dispensing cabinet. So this is an option if you have somebody that's on it frequently. But generally, my nurses are poking those nifedipine capsules. So it's an example of an old drug that we've kind of repurposed in pediatrics, and we just kind of make do with the dosage form that we're given. Something else we looked at recently was the osmolality of oral medications, in particular in the premature infant population. So several years ago, the American Academy of Pediatrics came out with a recommendation that enteral feeds should not exceed 450 milliosmoles per kilo. And other studies have suggested a maximum osmolality of 500 milliosmoles per kilo for low birth weight infants. Again, this is not really proven. It is really a theoretical concern. But the idea is that if we give hyperosmolar medications alone or in combination with feeds, it can increase the risk for a lot of adverse effects, the worst one being necrotizing enterocolitis, but it can also cause, excuse me, feeding intolerance, as well as delayed gastric emptying. So this is our poster that we recently presented last year, and we found an osmometer, and we measured osmolality for over 50 medications that are commonly used in the neonatal ICU. So of the 52 medications, 43 of them had a measurable osmolality, and that osmolality ranged from under 100 to 10,853. So remember, our goal is less than 500. And so those with greater than 500 was 86%. So 37 of the 43 had an osmolality that was too high, according to what our goal is. So this just breaks it down to show you the number, and you can see 25% had an osmolality above 5,000, so more than 10 times the recommendation. And another about 56% were between 1,000 and 5,000. So really very few medications that we give to neonates are in that goal range. And we don't really know what to do with that clinically. Sometimes we'll dilute the medications, but a lot of times these premature infants, we really have to watch how much fluid they get because they, don't need as much fluid obviously as an adult. And so we have to be very careful between their feeds and their other medications about how much volume we administer to these patients. So again, this study just pointed out, again, our dosage forms are not ideal for newborn patients or premature infants. Okay, we're going to transition now to parenteral products. And this is a big interest area of mine and an area where I think we also need a lot of help. So in the adult world, when an infusion is ordered, a commercially available bag is usually available. For example, say an adult antibiotic dose. A lot of those come pre-made. A label is printed out in our pharmacy. We attach it to the bag and we administer or dispense it to the floor for administrations. In children, it's quite different. Almost everything is going to have to be compounded. So for example, a dopamine infusion, that comes pre-made for an adult. For children, we have our pediatric concentration that we use at our hospital, and we compound it using a vial and diluting that with a standard diluent. We draw it up into a syringe, and we label it, and we send it up to the floor. A lot of risks here. Compounding errors and contamination are the two I listed. I just want to stress how many points in this process there's a chance to make a mistake. We could miscalculate the dose that's needed. One time I was working in a NICU, and we had a few babies who one day we got levels of their antibiotic, of gentamicin, and the troughs that we drew were 4 times what we expected them to be. And they were so that's very toxic with gentamicin. And so we didn't know what happened. So we went back and realized that when they were compounded, the compounding pharmacist had used the gentamicin concentration that's 4 times higher. She had used the 40 milligram per ml instead of the 10 mg per ml in order to compound it. I had another instance in a hospital I used to work at where I was working actually as a technician. This is when I was a student. And I was compounding with another technician, and she was making an antibiotic dose, but there was a vial of epinephrine that looked almost exactly the same as the vial of the antibiotic, and it was in the hood with us at the same time. And so she compounded the antibiotic, but using the epinephrine. So that child, when they administered that epinephrine, again, the nurse thought it was an antibiotic because that's what the label said. The child had a cardiac arrest. Fortunately, the child recovered, but these are the kind of errors that are so easy to make when we're compounding these medications in these hoods. Fortunately, the contamination issue is much better than it used to be. The New England compounding disaster has really benefited patients in that the regulations that restrict us now and that the USP 797 guidelines that are being updated are they've really been greatly improved since that time and since even 10 years ago. And so our chances of contamination are much less as long as those guidelines are being followed. Again, it was a horrible disaster that happened, but fortunately, I think pharmacy is moving in the right direction. I know at Rutgers, we were actually able to create a sterile compounding course because of that disaster when we didn't have a full course for it before. So I also want to talk about how we give these parenteral medications to children. So we use pumps in the hospital. The pump I first want to explain is the Baxter pump, which is on the left-hand side of the screen. So this is a large volume pump. And what's nice about pumps these days is we call them smart pumps, and that's because they have libraries in them. So the nurse can actually go through and choose the medication that she's going to give, and it will have what we call guardrails in there. So for example, for antibiotics, if she's trying to give a dose that's way too high, it would stop her, or way too low. And so those are all built in, but they are built by the hospitals themselves. And I've taken part in our large volume pump. I've helped to build the pediatric library that's in there. Most of the time for children, though, we're dealing with very small doses and very low infusion rates. And so for those types of medications, we're going to use syringe pumps. So the two that I have on here, the top one is the FarmGuard, is a Medfusion pump. That's what we use at my hospital. And then I also have the Alaris pump in the bottom right. But those are probably the two main pumps that are on the market. There are others that are out there, but those are kind of the big ones that I see that my colleagues use. So they're both built with libraries in them. And so we can update them. Actually, I just got told this morning that our server is down, though, so I can't update my pump library. I tried to add remdesivir to it for our COVID patients, but because the server is down, it's not talking to my pumps, and so I couldn't update my library for that. So there's a real-time example for you with that. But basically, when we have these medications in syringes, this means that we have to compound each one of those. So whether it's an antibiotic that has to be in a syringe or an infusion, say fentanyl or dopamine, et cetera, we're going to have to put it all in syringes. And absolutely none of these are commercially available. So all of these syringes require compounding. And so one of the safety initiatives that's happened in the last few years is called Standardized for Safety. And I've been fortunate enough to be part of this group. So this is an FDA-sponsored initiative. It started in the state of Michigan, and the FDA picked it up excuse me, with the American Society of Health System Pharmacists. And they're creating these national standard concentrations for many different things, everything from compounded oral liquids to continuous infusions and intermittent infusions. So I've been working with the Pediatric Continuous Infusions group. We actually just had our last meeting yesterday, and so our final list of standard concentrations is going to come out hopefully in the next few weeks. And the idea of having a list of standard concentrations is that all hospitals can be using the same concentrations throughout the country. It'll increase safety for patients being transferred. It'll also hopefully help prevent some of the rogue practices of some hospitals where concentrations are made up without stability and stability and sterility information. And so the other goal, though, is that we hope to encourage manufacturers to help produce these in standard concentrations. So if we have a standard list, we're hoping that they'll be able to, that will give incentive because most hospitals that take care of children would want to purchase it. And a final example in terms of the parenteral world is our surviving sepsis guidelines, which just came out a couple of months ago. And these are guidelines for the treatment of sepsis in children. And one of their recommendations was about the use of pressors in our shock patients. And so they suggest both epinephrine or norepinephrine over dopamine. So either one of those are recommended before dopamine. But unfortunately for us in pediatrics, the only one that's available pre-made is dopamine. And that's what we have in our crash carts. Epinephrine and norepinephrine both need to be mixed by the pharmacist or the nurse that's at the code. When you are in this kind of emergency situation and there's a child in shock in front of you, you don't even know what 2 + 2 is. So the idea of compounding a drip is extremely nerve-wracking, and the hands are shaking, and you're trying to remember what's our standard concentration and how do I mix this? So it's very, very difficult. And so my pediatric intensivists have said that they would rather just hang the dopamine for the first 20 to 30 minutes while they're waiting for the pharmacy to mix an epinephrine or norepinephrine drip. They're willing to take that time and just hang the dopamine because it's available and wait for the pharmacy to do it in a controlled setting, even though there's going to be that time delay. So it's a good example of where we're making clinical decisions based on the dosage forms that we have. All right, so we're going to talk about excipients. I'm going to tell you a little quick story first, and that is again about remdesivir, which is our new COVID drug. And so we've been able to use this. We've used it in a couple of kids at my institution. And the issue in terms of excipients that we've had with remdesivir is IV, but it comes 2 different ways. It comes as a powder that needs to be reconstituted, and it also comes as a pre-reconstituted liquid. The issue is that it has an excipient in it, and I'm going to try to pronounce this. It is sulfobutyl ether beta cyclodextrin sodium salt. And the excipient is in both forms, but it's more so, there's more of it, a higher concentration of it, I should say, in the already reconstituted liquid form. And so the powder form has less of it. And so that, according to the company, is the preferred form for children. And the reason they say that is because of this excipient is not good in renal dysfunction. And so, which is a little confusing to me because usually kids have great renal function, at least compared to adults. But the recommendation from the company is for kids under 40 kilos to get the powder form. Now, we've just received a large amount. We actually have a pretty good supply now. I just got updated by our infectious disease pharmacist earlier this morning. But the only remdesivir that we have is that liquid form, which is a high amount of excipients and is not recommended for use in children. And so here we have this drug that has pretty good safety data, and we want to be able to use it for our COVID patients. And now I have to make a decision: am I going to accept the proposed toxicity of this excipient as a risk when I give this to my patient? So to begin with, I wanted to discuss the kids list. This is another group that I've been fortunate enough to work with over the last few years. The KIDS stands for Key Potentially Inappropriate Drugs in Pediatrics, and it's meant to be a list of potentially inappropriate medications and excipients for children. A similar list, which is called the Beers list, as named after Dr. Beers, was developed in the mid-1990s, and so it's been around for about 25 years now. And so our idea was to create a similar list for the pediatric population. So this was just published last month. And then the first table in it, table 1, is a list of all the drugs and their risks. And then table 2 is our list of excipients. So when we came up with this list, we really tried to be guided by the literature, and we cited everything that we put in here so that people and readers who can look at it can make their own conclusions and pull up these references. But this is the list of excipients that we found definite risks for. Some of them are ones you probably know: benzyl alcohol, that we avoid in neonates up to a certain dose. Other ones that have very classic historical stories, like the E. Farrell syndrome with polysorbate 80. And then the one I wanted to bring your attention to, because it's fairly pervasive in our world, is ethanol or alcohol. So it is in several medications that we use in children, and a prime example that I often give is with dexamethasone. We often give dexamethasone for kids with asthma or croup. And, during these seasons, say the fall and winter, multiple times in the ED every day, we're giving this medication. And the dose is 0.6 milligrams per kilo for one dose. Unfortunately, though, it's a very dilute solution, 0.5 milligram per 5 ml. So that means the dose is going to be 60 mLs. And if you use the elixir, it's 5% alcohol. So we're not going to do that. And so what we do is we actually give the IV form orally. And now our 10 mg per ml IV form means that the dose is only 0.6 mLs. Methadone and phenobarbital are often used in our neonatal population. Methadone for our patients who are born to mothers with drug problems. And then phenobarbital obviously is an anti-epileptic. Phenobarbital has such a high alcohol content that some NICUs actually choose to compound it from scratch rather than use the pre-made commercially available product, because the alcohol content is so high. Albuterol, the form that we use for our patients in status asthmaticus, is a 20 ml bottle, and it contains benzalkonium chloride as a preservative, which is a known bronchoconstrictor. So it's completely counterintuitive to the idea of treating an asthmatic patient. Our preservative-free nebules that are available are only available as high as 2.5 milligrams, and we often have kids on 15 or 20 milligrams an hour. And so just the work required to empty that many nebules into the nebulizer every hour is just, at my hospital, for example, we don't have the respiratory therapist workforce that would be able to do that. It's just too much work. So we end up using the benzalkonium chloride product, unfortunately. I actually called this company a couple of years ago and talked to them about it and explained that if they made a preservative-free bottle and just took that ingredient out, that every hospital in the United States would buy it. But they didn't, I never heard from them. This is just a study showing that the patients who received albuterol with the benzalkonium chloride in it had a decrease in lung function over time. I wanted to talk briefly about the ketogenic diet and carbohydrate content of medications. So the ketogenic diet has been growing in popularity for the past 20 or 30 years or so. Of course, we're all familiar with it as a diet as well. It's quite popular here in the United States right now. And oftentimes these patients are going to be limited to 10 to 20 grams per day. The picture at the bottom comes from the Charlie Foundation, which is a foundation that works to support and provide resources to parents and caregivers who are on these medications for seizure, or on these diets, I should say, for seizures. And so you can see a classic ketogenic diet, they're going to be on a diet of 90% fat and only 4% carbs, which I always teach my students that that's the amount of carbs that you basically get by accident when you're trying to avoid all carbs. And so when we're talking about this small of an amount, any carbohydrate content that they get from medications is going to mean something. So usually what happens is I will total up the carbs from the medications for a patient and let our dietitian know, and she'll account for those carbs when she's calculating the diet and what goes into the diet. The problem is that I most of the time cannot find an answer in terms of how many carbohydrates or how many grams of carbs are in a drug product. Even calls to drug information sources at the drug companies often does not result in information. And so oftentimes we don't know, and so oftentimes we'll send them to compounding pharmacies to make carb-free products. So it's just a very difficult situation. There's times when I've ordered specific products for a patient just because I knew the amount of carbs. Okay, so it's better to know so that we can account for it. And even things like toothpaste and deodorant have to be considered because the carbs from anywhere count. A lot of times my pharmacist will say, oh, it's a sugar-free formulation, it's a fine liquid to give this kid, but sugar-free does not mean carb-free, and a lot of those medications still have carbohydrates in them. Gluten is a similar story. The FDA released a draft guidance, I should say, a couple of years ago, and just highlighting the importance of listing the amount of gluten that's in a medication, because some patients will completely skip a medication if they don't know how much gluten is in there, and so it's just important if it's in the medication that it be listed so that they have this information. All right, now we're going to talk about tubes, and I have another coronavirus story. So my pediatric ICU was actually converted into an adult ICU about 6 weeks ago because we needed the adult ICU space. And so I've been turned from a pediatric pharmacist into an adult pharmacist. Fortunately, last week we discharged our last adult patient from my unit, so we're back to being a pediatric ICU, which I'm very happy about. But during that time, I got the chance to care for some very sick COVID patients who were on ventilators and had a lot of tubes for administering both nutrition and medications. One medication that we use pretty frequently was a medication called Xtampza, which is an oxycodone extended release formulation. We like it in pharmacy because unlike other extended release oxycodone preparations that can't be crushed, this has a capsule and that we can open. So what we found was our nurses were giving it down tubes. However, for a particular patient, the nurses started complaining that the tube was clogging, and clogged tubes are not good things. And we couldn't figure out why. And I have a very resourceful pharmacy resident that's on rotation with me right now, and she was able to look up that the information on Xtampza. And buried deep within our drug information sources, we found that Xtampza should not be mixed in water before administering via a G-tube, which is usually what our nurses do. If they crush a medication or open a capsule, what they're going to do is mix it with a little bit of water, then suck it up in a syringe and administer it via the tube. So just a real-time example. So we did some education with the nurses and told them what you're supposed to do is just empty the powder into the tube and then flush it with water behind it to help prevent that clogging. So here's a picture. This baby looks very happy to have this NG tube in. These are NG tubes. We use them all the time in the hospital to give both nutrition and also medications. And then these are G-tubes, which are obviously a little more permanent. And you can see the length of the tube is fairly long. And so these tubes will go either in, the stomach, but they can also be put into the intestines as well. So liquids work very well, but we'll talk about the issue of syringes that we have. Crushing tablets is okay, but again, like I said, sometimes these can be a disaster, and clogged tubes are bad. And so this is from the Feeding Tube Awareness Foundation. It says medications, especially if they're thick syrups, crushed tablets, or time-release balls, are common cause of clogs. And so it talks about ways that you can unclog them, including carbonated beverages, pancreatic enzymes, and this clog zapper, which is an enzyme combination. And then just real quick, because I know we're running out of time, ENFit is a new type of tube, or not tube, I'm sorry, syringe and connector. And so on the picture on the left, the syringe on the right is our classic oral syringe, and the one on the left is the ENFit. And so the idea is that it will fit with the ENFit syringe adapters are the connectors on G tubes, and also minimize the loss of drug and the dead space. And so that became an issue. This is an ENFit small volume syringe. And so there was an issue initially with some dead space in there and losing some dose, but that has since been fixed. And so the idea is that in the United States, we'll be transitioning to these ENFit syringes throughout the US, and that is the goal. There's more information on this if you're interested at stayconnected.org. So finally, in conclusion, I wanted to bring up some of my favorite new products that I think are thinking outside of the box and are really good for kids. So we have Nasalium. The nose is like the hot new route these days. So as opposed to the Diastat rectal gel for seizures, this is just easier to give and patients generally prefer it. So we're hoping that we'll get some smaller doses. It's only available right now as 5 milligrams. But again, this is just a preferred administration route over the rectal route for seizures. Glucagon, we used to have to mix it outpatient, but they were able to come up with a way to put it into a pen form and a pre-filled syringe, making it easier for patients so they don't have to mix it outpatient. And it's also available as a nasal spray as well, which some of our patients are actually already on. Compounding kits are great. This is an example of first kits. And basically, this makes it very easy for pharmacists in the outpatient setting. It's basically 2 bottles. It's a bottle of diluent and a bottle of powder, and you mix them together, and you're good to go. And so this has made compounding a lot easier for a lot of different drugs in the outpatient setting. And there's been a trend towards newer commercially available oral liquids, which is fantastic for patients. Unfortunately, hospitalized patients often don't benefit from these because of the high cost of these medications. So finally, in conclusion, you really have to think about the dosage form and administration techniques when you're thinking about giving medications to kids. Ideally, they will taste good, they will be easy to prepare and easy to measure, especially for parents. They'll be safe for parents to prepare. And then also, they're going to be easy to administer for an entire course of therapy and contain safe excipients. I know it's a long list. The inappropriate osmolality for our premature infants, and also helpful for those of us that practice in the hospital. Commercially available liquids are definitely appreciated, and we're very pleased with that trend. But we need more standard concentration syringes and parenteral products for our pediatric patients. And with that, I think we have a couple minutes for questions, but otherwise I think we're going to email. I can respond via email as well.
Okay, thank you very much, Rachel, for that very insightful and informative presentation. I'll go through some of the questions, and at 2 o'clock we will close and answer any other questions following the webinar. How much overage in a bottle of medicine would you consider to be necessary?
Yeah, so this is a question that sometimes my pediatric residents, the medical residents, will ask me, like, how much should you write for? And I don't think there's a perfect answer to that, but I would say probably 10 to 15% is a good amount. I always tell them to write QS on their prescription so that the outpatient pharmacist can decide how much to give if the medication they're giving isn't going to be a whole bottle. But yeah, a little bit extra is always good because, again, the issues with spilling, and that's true for adults too, but also just spitting and kids that refuse to take medications and loss of drug is just always going to happen.
Thank you. Can you explain more about why tacrolimus sachet cannot be used by nurses in the unit? It wasn't clear what the issue was.
Oh, sure. So the tacrolimus packets basically require the nurse to tear open the packet and mix it in water, and that's just too high risk of a compounding procedure for our nurses to do according to NIOSH guidelines. And so it's better for them if what we do instead is we compound the liquid like we always have in our pharmacy, and we dispense it in oral syringes. Because again, our goal is for the nurses to be as little exposed as possible. And in the pharmacy, when we're compounding, we have a separate compounding area for hazardous medications. And so we know that we can take the proper precautions when we're in the pharmacy, but we just don't want to risk nurses mixing these powders. It's just too high of an exposure.
Okay, thank you. Question on the use of syringes. For new products, we, as in big pharma companies, may study the use of formulation in one brand of syringes and may supply those with the product, but have heard that also some hospitals discard syringes provided with the product in favor of using a quote-unquote standard hospital syringe. Can you comment on this, Philomena?
Yes, I would say that's definitely done, unfortunately. And sometimes our pumps can only handle certain syringes, so that's something we have to consider. And so syringe compatibility is definitely a very big concern and kind of a hot topic now that we don't know much to do with, or we don't know what else to do with, because when we get specific syringes for a specific product, it's very hard in the when we have a 600-bed hospital, which is mine is, to say, oh, those syringes are only for X drug, and we have like 500 other drugs that we're mixing today. And so just in terms of workflow, that's very hard to separate out. And in terms of our, the amount of our staff that we have so many different, I don't even know, over 100 employees in our pharmacy. And so just to train people to remember that you need X syringe for that one particular drug is just very difficult. And so that's why we try to standardize things as much as possible.
Okay, thank you. One last question. The way that manipulation is defined in the study mentioned is a different definition of manipulation that industry and regulators have adopted. Could that data or study be analyzed to look at off-label manipulation specifically rather than measurement as a manipulation? And how could that change a percentage of manipulation?
Sure. So the way we looked at it was as pharmacists and, thinking about how nurses handle medications too. And that was kind of the lens that we wanted to approach that problem with. Because again, what we see in practice is every time we do something to a medication is a chance to make a mistake. And so that's kind of the lens that we wanted to look at it rather than from the regulatory side of things, because again, we just wanted to count every time that we did something to a drug before it went into the patient, because each time something happens to the drug is a chance. I could go on and on for days about the different ways that we make mistakes in the hospital. And again, I really stress that the least amount of manipulation that we can do is just the safest. And every time I can, I'm changing kids to standard adult doses if their weight allows it, because it's just so much safer when we have a commercially available pre-made product. Okay,
great. Thank you very much, Rachel. Again, any unanswered questions, we will follow up with those askers following the webinar. So at this time, I would like to close the question and answer portion and turn it back over to Mahalea.
Thanks, Beth. Thanks so much, Rachel, for a terrific presentation.